Good evening, everybody. Dr. Ajay has already covered about the diabetic metabolic control and laser photocoagulation for diabetic macular edema. So I'll be just discussing further about the clinical trials in diabetic macular edema and their practical relevance. Laser photocoagulation has been a gold standard for diabetic macular edema treatment, but the treatment purpose was only to stabilize the vision. DRS gave us guidelines to treat the clinically significant macular edema, and laser therapy reduced the relative risk of losing 15 letters of visual acuity by 50% compared to different treatment. But we never thought about in terms of improvement of vision. So there was unmet medical need to look for therapies where we could see visual improvement also. So some of the protocols I will be discussing, it was a protocol A by DRCR-NET. It was a pilot study of laser photocoagulation for diabetic macular edema. What we have been doing, a modified ETDRS laser photocoagulation, where we treated directly to the leaking macroism and grade to the diffuse leakage. It was mild macular grade treatment laser technique, which was given by this protocol to give small mild burn throughout the macula in areas with or without macular edema, and no direct treatment to microaneurysm, just to see whether this treatment is effective or not. It showed that laser is effective, but it is not as effective as what we have been doing at modified macular grade laser. So, but the visual acuity improvement was similar in both the cases. Another protocol B, it was a randomized trial comparing intravitreal steroid triamcinolone acetonide and laser photocoagulation for diabetic macular edema. It was around 2001 when initially the steroid effect was first seen in treatment of diabetic macular edema, though the short-term improvement was there in visual acuity, and there was a rapid decrease in retinal thickening on OCT. So this trial was done to compare the efficacy and safety of preservative-free IVT 1 milligram or 4 milligram with focal or grid laser. So, and you can see by the graph, we have the pointer. So actually, you can see in the upper graph, the visual acuity improvement is quick with the 4 milligram dose, and with 1 milligram it is less than the laser effect. But if you see over a period of 24 months, the effectivity of laser is more than this steroid treatment. So basically saying that the effect of steroid wanes off over a period of time. And even the macular thickness also, it decreases first, but again you can see the laser work is doing better. So the take-home message was focal or grid laser currently is the most effective treatment for DME, and steroid effect is not is short-term actually. In protocol E, it was a pilot study of peribulbar steroid triamcinolone for diabetic macular edema. In this, posterior subtenon injection was given, anterior subtenon injection was given with or without laser, and the dose was 40 milligram in posterior subtenon and anterior subtenon 20 milligram. There was a trend towards reduction in retinal thickening over the 34 weeks in all 5 groups, but the degree of reduction in retinal thickening showed no consistent pattern. So saying that it was also not a very effective treatment to reduce the macular edema by giving steroids in peribulbar area. In protocol H, it was a phase 2 randomized trial of BEVACIZUMAB for diabetic macular edema. It was compared to the focal laser, both the 1.25 milligram and 2.5 milligram BEVACIZUMAB dose was used to treat eye, and it had a greater reduction in central retinal thickness at 3 weeks. But the question was whether increasing dose up to 2.5 milligram reduces more thickness. It was not evident in this study. And what is the duration of reduction in OCT measured retinal thickening following the initial injection of intravitreal bevacizumab? It was shown that at 3 weeks, the effect is maximum, or it plateau, or it decreases in most of the weeks after 4 weeks. So basically it is the timing, 4 weeks is an optimal time to give the second injection rather than at 6 weeks. And another question was, is there a greater reduction in OCT measured retinal thickening using intravitreal bevacizumab followed by laser photocoagulation compared with intravitreal bevacizumab alone? Combining laser photocoagulation with bevacizumab resulted in no apparent short-term benefit or adverse outcomes. It means the monotherapy was good enough. In protocol I, laser, ranibizumab, and triamcinolone was studied for the diabetic macular edema. There was sham group with prompt laser, and another group had ranibizumab treatment with prompt laser, and one ranibizumab with deferred laser, and another is steroid triamcinolone with prompt laser. And intravitreal ranibizumab with prompt or deferred more than 24 weeks focal or grid laser had superior visual acuity and OCT compared with where the treatment was laser alone. And 50% had substantial improvement, more than 10 letters, while 30% gained more than 15 letters. In pseudophakic eyes, it was shown that giving intravitreal triamcinolone has a better effect than giving anti-VEGF, and it was much safer in terms of not having more chances of cataract because the patient is already pseudophakic. In the RESOLVE trial design, there was a sham group. Another patient received 0.3 milligram and another patient with 0.5 milligram. And the dose was increased, doubled when there was no OCT decrease in thickness. And in 0.5 milligram, it also doubled by 1 milligram. And the photocoagulation was done after 3 injections if the macular edema was still persisting. And you can see that there is a definite, all pooled ranibizumab group, there was a gain of 9.6 letters if you compare with the sham treatment. And mean CRT change also you can see there is in pooled group there was a marked change. So at 12 months, ranibizumab treated patients gained 10.3 letters in BCVA with a mean of 10 injections versus a loss of 1.4 letters in the sham group. And more patients receiving ranibizumab gained more than 15 letters compared with patients receiving sham injection, showing a clear benefit of anti-VEGF therapy. And dose doubling was more frequent in sham group, and a higher proportion of patients in sham arm received rescue laser therapy than the anti-VEGF therapy. As far as the safety was concerned, it was also addressed, and there was no increase of any adverse effect of cardiovascular or cerebrovascular events in the control group and ranibizumab group. In RESTORE group, it was a 12-month randomized study with visual impairment due to DME, ranibizumab monotherapy and ranibizumab combined with laser or laser monotherapy was assessed, and ranibizumab injections were given every month for minimum of 3 injections, and until the disease activity was stabilized, they were repeated. And laser was administered in accordance with ETDRS guidelines. The primary endpoint for RESTORE study was the mean average change in best corrected visual acuity, and it demonstrated the superiority of ranibizumab either monotherapy or when combined with laser as compared to the laser monotherapy alone. And also, interestingly, ranibizumab group experienced an improvement of more than 10 letters than those on laser monotherapy, and 37% when it was only monotherapy, and 43% in combination therapy versus 15% in laser monotherapy. Another trial, BOLT study, which showed the effect of, assessed the effect of intravitreal bevacizumab or laser therapy in management of diabetic macular edema, and there was a gain of 8 letters in this study with the bevacizumab. In READ2 study, it was again anti-VEGF therapy, RETINAL, and along with or without laser was assessed. And you can see with alone therapy, monotherapy, there was 22% improvement. In Da Vinci study, role of aflibercept was assessed. It was given every 4 weeks, or 2 milligram every 4 weeks, 2 milligram every 8 weeks, and 2 milligram as and when needed. It also showed that mean change in BCVA for aflibercept arm ranged from plus 8.4 to 11.4 letters. So to conclude with the studies of DRC, RNET, READ, RISE, RESTORE, and Da Vinci, they are providing basis for evidence-based clinical practice in diabetic macular edema management, and the gold standard for treating DME is shifting to pharmacotherapy. Thank you.